Well, so this is a small crew, we can have more of a conversation. I have about half an hour, is that right?
Yep.
I haven't really timed myself, but cut me off.
There's a bit of time, yes.
Okay. And then after this presentation, I'm going to have to run to another session. I'm doing some teaching there. But I'll give you maybe a bit about myself, background about myself, so you kind of know where I'm coming from. So family medicine trained. I finished residency a couple years ago, in 23. I went to school, VCU for med school, and then residency was a rural program in the mountains in Shenandoah Valley in Virginia. And I got into technology about halfway through my training and pursued more of a corporate role right after residency. I stayed clinical about 1 day a week, and then I led an engineering team and product and at a practice called Next Level Medical in Houston. They had about 50 locations throughout Texas. They were urgent cares that then kind of upgraded themselves to have primary care service lines with employers. And I really came there for the primary care piece. And they were, tech enabling all of their operations. They were doing a lot of work with self-insured employers, and so that was really interesting to me. I was there for a couple years and got a lot more into the technical stuff, but also saw a lot of issues related to workforce and quality, and that kind of inspired me to go off and start my own company. And so I spend most of my time on the technology side of things. I opened up a small virtual DBC practice. I have licenses in Texas and Massachusetts. I just moved to Boston from Houston, so that's my new home. So trying to stay in the game as a physician, but can't do it at a large scale or full time, because I really like technology, and I think there's some interesting ways to improve primary care through what I do. And I titled the talk Primary Care Skills Index more of just to kind of get I think people's ideas going about what primary care, how it could be measured and developed. And so some of the questions that I think would be helpful to cover during this would be thinking about what does good care actually look like. And there are many answers, stakeholders' perspectives on this. And then how do we capture what we value? And then how can we actually make it lasting in the future of what we say should be good care? Anthropic is one of the big companies, kind of like OpenAI, where they have their own large language model, Claude. And so I follow a lot of their work, and they put out this economic index earlier this year, analyzing how technology changes our jobs. And they kind of made this claim around, instead of studying the occupations themselves, you look at the tasks within those occupations. And Luigi, I think, was saying earlier how some of the forms that get filled out by different team members. So it's not just the physician that always fills out the form, it can be the MA or the nurse. So it's that kind of approach is if we study the types of tasks that happen in healthcare, and specifically for us in primary care, I think that can be a really interesting way to think about how to develop the workforce. And so I'm going to cover a bit of workforce-related issues, technology issues, and then we'll see how this all ties together related to education. This is just an example from the Anthropic paper where they kind of showcase, they look at how people use their chatbots across different professions and what type of tasks they're getting help with, and then they organize those tasks and basically classify them according to different skills, and which of these tasks can be augmented with technology and which ones can be automated away because they're so routine. The second force, I think, kind of in the market is what's happening with the just composition of the primary care workforce. Like 15 years ago, physicians made up more than 2/3 of the workforce, and as a lot of docs retire and then schools ramp up to fill a lot of the gaps, physicians now are making up less than 50% of the workforce in primary care. And so that creates all sorts of changes that I think we're really not positioned to deal with. The technology piece that comes in here is what's really interesting to think about. This is from one of the co-founders of OpenAI, brilliant engineer, and he made this observation that traditionally technology has always went from government to institutions or corporations and then to the regular people. But what's weird about AI stuff is that actually the people get it first, and then the institutions are still trying to figure out how to put guardrails or other things around technology. And so this is just one of those phenomena that we're experiencing right now, and people are trying to make sense of it. So continuing on the technology trend, there's been a lot of research out there. This is from one of the Google groups from earlier this year when they try to compare how does AI do with the tasks that doctors do. In this case, it was primary care. They're able to say that the technology is so much better in all these different domains, not just the IQ, but also the EQ part that, related to empathy, and this is based on the conversations that happened with thoughts, and there's some issues obviously with studies like that, and I'll highlight them later. Another study from a couple years ago, even when those chatbots were not really good, they tend to perform much better on empathy ratings and quality ratings when it had to do with patients asking questions about health on different social media platforms. I think this study was based off of data on Reddit. And another example here is this is around performing differential diagnoses. When AI is paired with a physician, it tends to do, or a clinician, it tends to do less than just AI by itself. And then clinicians without any tools tend to do even worse. And so this is just very counterintuitive, but it is a phenomenon that we're observing with all the research that's coming out. And there's lots of studies, this is just including an example, where this AI performance is exceeding AI performance when paired with a clinician. No one's really trying to understand why that's happening. There's some hypothesis. We won't get into that, but I just wanted to illustrate that this is a trend and an observation that's happening. And so that kind of brings us to that initial point about, if we think about tasks, which tasks are better for whom? Whether technology or the human or a combination of the two. And so the conclusion from current research is that humans are generally better than humans plus a tool, whatever tool that is. And now research is saying that the tool is just way better. Obviously there's issues with that, but this is just one example that came to mind from a TED Talk I saw, is that there's evidence now that EKGs can elicit all this data that we're just not trained to notice in them. And it's because the human eye can't tell, but patterns can. And so there's evidence that you can tell the age and sex based on an EKG, even diabetes risk, anemia, which is kind of wild. I mean, we're not, we're kind of used to detecting heart attacks or abnormal rhythms. But this is just this example where this tool is so powerful, but not necessarily to us because we've not been trained how to use it. So then what do you do about this equation? Do you teach the human how to use the tool so that the capabilities and skills elevate? And I don't know if that's the right answer, but that's just a way to think about it. And so if we took that to be the path forward, there are some researchers. I was at a Change MedEd conference last week in Chicago that's hosted by the AMA, and met Rodrigo Gamero. He's a researcher, doctor at MIT, and he's really focusing about what doctors should know in AI, and from the lens of competencies and as it relates to medical education. So I think this is, some people are really thinking about how do you take that human plus tool part of the equation and make it perform better. I kind of question this entire equation because I think we're getting some of these results because we're measuring the easy stuff to measure and maybe not really what matters. And that brings me to that question, is what does good care look like? And it can really mean a lot of different things depending on who's paying for it, who's receiving it, who's delivering it, however you slice it. So just to facilitate some conversation, because it's such a big question, one framework, I'm not saying this is the right framework, this is just how my brain works. You basically have an axis where one is a process quality versus an outcome quality, and an individual level or a system level. And so if we think about the question, what does good care look like, whether trying to fit something on that or just irrespective of this graph, can someone just name a couple things of what good care looks like first thing that comes to mind?
Continuity.
Continuity, okay. So continuity, I would probably put that around, maybe a process at the system level, potentially, right? And again, just a way to kind of frame these things. Anyone else want to say something else?
Compassion.
I'm sorry?
Compassion.
Compassion, okay. So that could potentially be either a process or an outcome thing, more at the individual level, potentially, right?
For me, it's health, and not necessarily the absence of disease, but your ability to truly live out your best life.
Okay.
So you may have diabetes, but your diabetes is excellently managed. You're not having an amputation. You're not suffering from kidney disease.
Yeah.
So health, which is the absence of disease, or having comorbidities that are well managed.
Yeah, so patient-aligned
Not
goals.
advanced.
And so I would put that more in the outcome category at the individual level, right? And crudely speaking, on the left-hand side would be the operations that drive a lot of the outcomes that follow. And I pre-filled some examples just to kind of help illustrate, in case it's not clicking, but smooth navigation, being seen and understood, or safe prescribing, that's where I would put things related to process at the individual level. Now, the outcome of those processes would be receiving the correct treatment, kind of what you were saying about health, a lot being aligned with patient goals, symptoms improve. Around the process and the system, it's more that technology is working as expected, guidelines are followed, and teams are communicating well, the dynamics are functioning, and then kind of on the system and outcomes level, you have healthier communities, it's equitable care, resources are used widely. And I can make these slides available later too. So now, if we named what we think good care looks like, how do we capture that? I don't know, but we can think about it. So again, we can kind of utilize the same axes framework to think about if we named those things, how do we capture those things? I'll just kind of put out what I thought, and we can always talk later. But for process, we can measure like Net Promoter Score. We can look at chart reviews to measure for quality. We can look at safety reports. On the outcome side at the individual level, patient-reported outcome measures, clinical metrics, readmissions. And the system level, is care being done appropriately? Are you doing the appropriate referrals? Are you following the guidelines and evidence? And then, population health level stuff at the system and outcomes is around vaccination rates or cost-effective care. So those are the things that we can capture. I think there's a lot more to it. If anyone can think of other things, just feel free to interrupt. Now, just to kind of zoom out a bit and then recenter to what I'll show you next. So the left side of the graph is like how care is delivered, and that's really informing the outcomes portion of the graph. And the how care is delivered is really changing because of the workforce shifts. We saw how the composition of the primary care workforce is different. And then also we have new tools, and that's just changing the things that we're very much used to. And I just wanted to say that with those, with that combination, we really can do things differently. Just think of that EKG, how you can notice things that were previously invisible. I really think that and this is where my work comes in, what I find really interesting is that we really can measure and develop skills that I think define good care, but we're just like so early that it's a little painful. One example, which is kind of not the exciting example, but we can look at clinical notes and we can create a skills index, which I think helps us create a more capable workforce. And so this is just to illustrate it's not a real patient, but some of the work that I do is basically look at charts and then extract information and give feedback to whether I work with students, medical students, NP students, PA students, or it's actual people in the industry who are required to have supervision because of the licensing laws and whatnot. And so AI is really good at being able to consume information and then present it in a way that like a really talented preceptor would. And so that's a way to upskill somebody. And then you can even look at individual condition. This is also another synthetic data example for like someone with elevated blood pressure and they did not address it in their chart, you can basically have technology coach you on whatever criteria or qualities or domains that you directed to do a good job on. And so you kind of can get this like personalized feedback. Then you can kind of roll up these feedback suggestions and then look at how someone's doing across different conditions. And that's based on their track record of what they document. And then you can also look at competencies, not just conditions. And those competencies you can define whatever you value in your workforce. And then you can actually roll those up and see how different clinicians are doing across the entire practice or entire group based on the things that you told the technology to measure, which are obviously some limitations because we're not measuring everything. We're able to look at stuff that's just in the notes. And then you can kind of get to this skills index, so to speak, at the practice level or group level that can guide you to understand who needs to be supported in different ways. So like when beginning to work with different residency programs, we're looking at educational gaps and understanding what types of patients someone has not seen, even if they're about to graduate. How can we supplement all of that? So if that is, a vision for how we can maybe get better at measuring and developing skills in our colleagues and future trainees or future doctors, like how do we make this stick and sustainable? And I don't have an answer to this. I think it's just a good question to ask, and this is maybe something to walk away with and ponder. One thing that I do think about a lot from the lens of clinical performance is, right now what I showed you around clinical notes, so the axes are a little different here. So still process to outcome, but if we just look at that, what is good care, a lot of the responses that I get when I talk to people, it's all of the items that mean good care relate to human connection and really the emotional intelligence between humans. The IQ stuff, it's reading all the books and knowing answers to different guidelines and tests. And so I kind of showed you the clinical notes example, how we can use technology to make ourselves better. But I really think that the interesting part is us defining what does good care look like and the things that we're not measuring. And then how do we actually utilize technology to measure and then develop those things. Again, don't know the answer, but I think that is going to be kind of the next interesting thing. And if we don't define these things, then it's going to be technology companies and VCs and investors who are going to tell us what's important. So therefore, I think we should really be participating in these conversations and leading by example. That's all I got right now. And you all can send me an email. I can give you my phone number if someone does phone. But yeah, here I am. Thanks for listening. Thanks for the opportunity, Larry.
Thank you.
Excellent.